Hi everyone, it's Dr. Andrew O'Leary here to talk to you about documentation, which is, on the face of it, a very boring topic, but if you do it well, it will save you a lot of time and possibly save you a lot of litigation later down the line. So, we're going to talk about how to get across the salient points when you're writing everything down, and you're going to have to consider the fact that you might be documenting overnight, having seen a sick patient, and you want to give a nice clear picture of what's happened out of hours when the day doctors weren't there, so that they can refer to that. And you've also, we don't have the kind of legal, medico legal culture that they do in the US, but there is that aspect to consider. And I can't remember the statistics off the top of my head, but I think it's maybe once or twice in every doctor's career they will run into issues at any one time. And probably the best thing you can do aside from practicing well is documenting properly. So one take-home message, possibly the most important thing here is if you do something noteworthy, you better note it down, because there's a mantra that we use in medicine: if you don't write it down, it didn't happen. So no one wants to hear a story about what's been going on. No one wants to hear about the chat that you had with the patient when you first walked in, unless there's something relevant. In psychiatry, maybe some things they said could be very relevant, but there are certain things to note down, and there could be things that you want to get from them that could be really useful, like taking down a phone number for their son. If they start talking about their son, what's their phone number? If it's an old lady who's had a fall at home and you need a classical history, how's she been? Are we thinking there could be a dementia diagnosis in the works here? How are we going to figure that out? Getting all these other extra bits of information that you wouldn't necessarily do on a regular ward round, absolutely fine. Neighbours' cats' names and favourite foods, not so much. You can talk about them, but don't write them down. So we'll have a look at, I've got an example here, if you can read any of this, for example, ward round. So what you're going to do when you get in the morning, if you get in, say, half an hour before the consultant, particularly on medical ward rounds, you're going to prepare the notes. So I've just given you a bit of an overview here of a kind of sensible approach to doing that. So getting the right amount of information down so that when the consultant comes in, you say, we've got 3 new patients, and you've prepared them, they're going to ask you about them. You can have the sheet in front of you as a little prompt to remember the details, and then get on with seeing them afterwards. But what you want to do here is, so I'll show you these bits here, writing down the issues that they have. So a new admission is unlikely to have just a single problem. They're likely to have a few issues. So I did gastro for 4 months, so it's the perfect example of complex patients. So not only might a gastro patient come in having decompensated liver disease, if that's the case, they may be an alcohol withdrawal very often, and their liver biochemistry may be abnormal as well. So you can have a look at their background. I don't know if you can see my cursor here, but I assume you can. So their background, keep it nice and simple, but put everything noteworthy in there as well. And then just say briefly what happened, what led to them coming in. Were they brought in by ambulance? And just be sensible about it. Presentations will vary drastically, but a sentence or two on what brought them in. And then down the side here, I like to use the margins. You can use the other side of the page across here, but the margins are a good spot to get down the obs. This all gives you great context, get the numbers in. It's going to help make the decisions on the ward round. So get the obs in, get the bloods in. Have they had any imaging? Aside from your documentation here, having that imaging up and ready. So it's all well and good if you look at the chest x-ray. Some consultants will be more than happy that you've said the x-ray is fine. Don't just look at the report. Have it open and ready on a tab, so you can whip it up and amaze them that it only took a few seconds. They really like that because you can crack on, or you might really like that because you spend half the time getting pictures up during the ward rounds. You're not going for lunch before 2 o'clock. And then I'd leave, ward rounds could go on for a couple of pages, especially a very busy, complex medical ward round. But say you can squeeze it onto a page, you can then leave space for your discussion when you go in and have a chat to them, and then there'll be an examination, and you can get these bits ready. It's only going to take a second, so you don't need to draw these on beforehand. But here's your chest and your abdomen, and then a short synopsis at the end of what's going on, and then you can have a several point plan. Don't forget at the end to sign it off. A lot of you will be given stamps with your name and your GMC number as well, so that's always good to put in there, and your bleep number, because especially on call, we'll see an on-call example on the next slide, but especially on call, if you leave the ward having written, even if you've done the best assessment ever, and you don't leave your bleep number, it's not so much of an issue for the F1 because the nurses will definitely have your number. But say if you were the F2 and you go off and they don't know your bleep number, then it's not too much use. But consultant name at the top. This is a ward round. Say what it is. Don't forget the time and the date. I like to put the ward on because sometimes when patients have prolonged admissions and they rattle around different wards for a long time, sometimes it's good to see really which treatment was initiated on which ward and what happened in different places, because necessarily if they're under different care, different things are usually going to happen. But yeah, get the names up there. At the very least, have the title up here, and then the information, the time and date over here, and then everything else. If you can get that prepped, then your ward round will go a lot more smoothly than it would otherwise. Different sorts of ward rounds. So I kept referring that would be possibly a medical ward round. This would be an orthopedic ward round, fraction off on the right, had a total hip, they're medically fit, get them home. So ask to see patients. So we'll quickly do this on-call scenario here. We've only got a couple of minutes left. Again, make sure you put who's leading the show. Of course, in the morning on the ward round, it's the consultant, but you're leading the show now. So this is F1 O'Leary on call. Gives them the context that you're on call. You've been called out of hours. So immediately, if I were to read that in the notes, I think, okay, this patient was possibly unwell out of hours, rather than just flicking past it thinking it was another ward round. Fine. So I would say ask to see patient for whatever particular reason. So what were you told over the phone? Give a bit of context. So flip back through the notes. There might be a lot more to it than this, but say what they came in with, when they came in with it, what are they being treated for right now, and what's the plan roughly. Give yourself a bit more context. Have a look at the medical history and what medicines are they on, what have they been started on since they came in, and in this in this scenario with chest pain, what does the ECG show, and is it looking abnormal? Do they need serial ECGs? That'd be part of the plan though down there. So again, very basic. Beyond that, it's just your history and your examination, and then what you think is going on, and then include your nice comprehensive plan. You're possibly, if they are sick, going to fill up a number of pages after this, because you'll go and do the ABG and you'll come back, you'll stick it in the notes. I shaded out a little bit here and on the previous one. Make sure the patient's sticker is on the top as well, because it's no good doing the most beautiful, perfect review and then not have the patient information at the top afterwards, because if that's left on the side because something else happens, they go off or do something funny, or you get called away to some cardiac arrest, you're not going to file this away perfectly and put the notes back in the trolley. If you get a cardiac arrest bleep, your focus on this is going to go from 100 to 0 in the half second that it takes you to start listening to the bleep go off. So fine, get that sticker on there. Make sure you date and time it. Say who is leading this, if it's you on call, everything in between. Make sure you sign it and put your bleep so you can be contacted properly. But again, if you're the F1, the nurses will have no trouble locating you, because as you'll find out, they'll be bleeping you regularly. So we've got common abbreviations. I mean, you'll just pick it up as you go along. The most time I have trouble is with the physios. They have all these funny acronyms that I don't know the meaning of. Common one I like to use is ask to see patient. So this, again, like when you're on call on examination, you probably know all of this. Probably didn't need to put this in. Medically fit. That means your ward round should only take a few minutes, so you can move on to the next one. I think we've got no issues. Being a bit cynical here. Yeah, fine. I don't think we need to go through loads of common abbreviations. You probably know them. So, yeah, hopefully your ward rounds will look a little bit like this, and your on-call reviews will look a little bit like this, and you won't get called by any lawyers anytime soon. So that's all. Thanks for listening, and see you next time.